Welcome, everyone. My name is Ted O'Connell. I'm one of the authors of Crush Step 1, the ultimate USMLE Step 1 review. This is the second edition of the book, and we're going through it chapter by chapter. This is part 5 of the Neurology chapter. We're going to start by talking about demyelinating diseases, beginning with multiple sclerosis. Multiple sclerosis, or MS, is an autoimmune disorder of the central nervous system, mostly affecting women in their 20s and 30s, which eventually leads to demyelination and inflammation of the CNS. As the name implies, multiple sclerosis plaques involving the white matter of the brain and spinal cord, and including cranial nerves, result from repeated damage and destruction to the oligodendrocytes over time. In addition to demyelination, inflammation results from T-cell entry into the brain via the blood-brain barrier, where it recognizes myelin as a foreign molecule and triggers inflammatory cytokines. The blood-brain barrier is not normally permeable to any types of cell unless the integrity of the tight junctions forming the barriers becomes compromised. MS can present as a variety of neurologic symptoms, such as visual problems, such as nystagmus, optic neuritis, and diplopia, dysarthria, dysphagia, muscle weakness, spasms, or paralysis, hypoesthesia or paresthesia, or bowel and bladder difficulties, such as constipation, diarrhea, frequency, retention, or incontinence. Sometimes patients may complain of worsening of symptoms when the body becomes overheated, such as stepping into a hot tub during hot weather or during exercise. The increased temperature slows or blocks nerve impulses. In other cases, some complain of electrical shock sensations down the spine or symptoms of trigeminal neuralgia. Typically, a patient presents with Charcot triad of scanning, telegraphic speech, intention tremor, and nystagmus. The most common presentation is optic neuritis, where the patient complains of sudden vision loss, which can be partial or complete, blurry or foggy vision, pain with eye movement, and some subtle loss of color vision, especially red. Because of the wide array of symptoms, MS can be difficult to diagnose. The Macdonald Criteria combine clinical, laboratory, and radiologic data. Neuroimaging using MRI with gadolinium contrast is a gold standard, in which multiple lesions or plaques of demyelination can be seen anywhere from the brain down to the spinal cord. Lesions around the ventricle-based brain veins are classic and are called Dawson fingers. Lumbar puncture can show signs of chronic inflammation and typically show increased oligoclonal IgG bands on electrophoresis. In addition, there is increased P100 latency of nerves when doing visual, auditory, and sensory evoked potentials caused by demyelination. Treatment of an acute attack of MS generally consists of high doses of IV corticosteroids for the inflammation and symptomatic treatment of pain, spasticity, and fatigue. Long-term disease-modifying treatments include immunomodulators such as interferon beta, fingolimod, glatiramer acetate, metoxantrone, and natalizumab. Deficits suffered during an acute attack may resolve or persist. Ultimately, the overall treatment goal is to prevent the increasing disability that results over time from recurrent episodes of relapsing remitting MS and prevention of the development into progressive MS. Acute Disseminated Encephalomyelitis, or ADEM. Similar to MS, ADEM is an autoimmune disease that produces multiple inflammatory lesions in the brain and spinal cord. However, it generally affects children and adolescents following viral, bacterial, or parasitic infection and requires an extended period of time to recover completely. Transverse myelitis. This demyelinating inflammatory process occurs across the thickness of the spinal cord following infection, immunization, or the development of MS. Depending on the level of the spinal cord and the tracts involved, patients present with motor, sensory, and sphincter deficits. Transverse myelitis should be on the differential of acute onset of extremity weakness and numbness. Other conditions on the differential should include Guillain-Barre syndrome, acute spinal cord trauma, compressive spinal cord lesions, and spinal cord infarction. Central pontine myelinolysis, or CPM. CPM, which is also now more commonly known as osmotic demyelination syndrome, is a complication of overly rapid correction of severe hyponatremia. The serum osmolarity is low in hyponatremia. With chronic hyponatremia, the cells make intracellular adaptations to equalize the osmolarity between the serum and inside the cell. However, if the hyponatremia is rapidly corrected, more than 12 millimoles per liter per day, the serum osmolarity will now be significantly higher than the intracellular osmolarity. This rapidly draws water out of the cell and damages the myelin. Patients generally develop an acute onset of dysphagia, dysarthria, and paralysis. No specific treatment other than supportive care is available once demyelination occurs. Although most patients die, some may live with disability, ranging from mild tremors and ataxia to spastic quadriparesis and locked-in syndrome. Leukodystrophy. This is a group of inherited disorders that leads to impaired growth and development of the myelin sheath. Leukodystrophy can be inherited in a recessive, dominant, or X-linked manner. For example, adrenoleukodystrophy is an excessive buildup of long fatty acids in the nervous system, testes, and adrenal glands, leading to progressive adrenal crisis and coma and death. Guillain-Barre syndrome. Guillain-Barre syndrome, also known as acute inflammatory demyelinating polyneuropathy, is an autoimmune disorder that affects the peripheral nervous system. Because of molecular mimicry following infections, often C. jejuni or CMV, there is an autoimmune attack on myelin of the peripheral sensory and motor nerves. A patient may present with symmetric ascending weakness starting distally in the hands and feet and migrating toward the trunk. Bulbar cranial nerves can also be affected, leading to facial weakness or paralysis, dysphagia, drooling, and difficulty swallowing and maintaining an open airway. Commonly, respiratory support is needed, for example, endotracheal intubation, because of impending respiratory failure. Sensory loss is manifested as loss of both proprioception and reflexes, along with bladder dysfunction. Autonomic dysfunction can also be seen in severe cases, for example, cardiac arrhythmias and fluctuating blood pressure. Suspect Guillain-Barre syndrome if a patient presents with rapid onset of muscle paralysis, areflexia, absence of fever, and a GI or respiratory infection in the past 30 days. Diagnosis is confirmed with lumbar puncture, which shows CSF with an albuminocytologic dissociation, which is increased protein without increased cell count. And a nerve conduction study, or EMG, will show prolonged distal latencies and conduction slowing. There are two treatment options. The first is plasmapheresis to filter antibodies out of the blood system. And the second is intravenous immunoglobulin, or IVIG, to neutralize antibodies. Most patients recover weeks to months after onset, but some may have residual disability. Some patients may have one or more relapses of similar symptoms, classifying them as chronic inflammatory demyelinating polyneuropathy, or CIDP. Charcot-Marie-Tooth disease, or CMT disease, an incurable hereditary sensory motor neuropathy that consists of a group of clinical and genetic subtypes in which there is a defect in the production of neuronal proteins involved in the myelin sheath and axon of peripheral nerves. Initially, there are intermittent, severe, painful muscle contractions that are disabling, but over time, there's loss of muscle tissue and touch sensation in the extremities. Generally, high-arched cavus feet are associated with the disease. Subacute combined degeneration, or Lichtheim disease. As discussed in the spinal cord pathologies, there's patchy loss of myelin in the dorsal and lateral columns caused by vitamin B12 deficiency. Patients typically present with weakness, paresis, numbness, and/or tingling in the legs, arms, and trunk. If the B12 deficiency is not corrected, damage may be irreversible. If a patient has B12 and folic acid deficiencies, The B12 deficiency should be corrected first to avoid precipitating this condition. Administration of nitrous oxide anesthesia has been shown to precipitate this disease in patients with subclinical B12 deficiency, while chronic exposure can cause it in people with normal B12 levels. Neurodegenerative diseases. Let's start with Alzheimer's disease. Alzheimer's disease is the leading cause of dementia, in which there is reduced overall synthesis of the neurotransmitter acetylcholine and diffuse cortical atrophy, especially in the hippocampus, because of the loss of neurons and synapses. Although the exact cause of Alzheimer's disease is not known, higher amounts of extracellular beta-amyloid core protein, or senile plaques, and intracellular abnormally phosphorylated tau protein, or neurofibrillary tangles, are seen on histology. Alzheimer's disease develops sporadically in most cases. 10% of cases are familial and tend to be earlier in onset. Early onset Alzheimer's disease is also seen in Down syndrome patients who carry an extra copy of the gene for A beta precursor protein, or APP. Early onset Alzheimer's disease is also seen in mutations in presenilin 1 and 2, chromosomes 14 and 1 respectively, which are subcomponents of an enzyme responsible for converting APP to A beta protein. Late onset Alzheimer's disease is seen in those carrying apolipoprotein E4, which is an isoform allele of the gene found on chromosome 19. Another isoform, ApoE2, serves a protective role in Alzheimer's disease. Alzheimer's disease is a diagnosis of exclusion that is clinically diagnosed. Short-term memory loss is usually the initial symptom. As the disease progresses, problems with long-term memory, executive function, and behaviors develop. Amyotrophic lateral sclerosis, ALS, or Lou Gehrig's disease. ALS is a fatal disorder that affects both lower motor neurons and upper motor neurons. The autonomic nervous system and cognition are spared. It is characterized by a rapidly progressive weakness, muscle atrophy, and fasciculation, which are lower motor neuron signs, as well as spasticity, which is an upper motor neuron sign, as well as dysphagia, dysarthria, and eventually respiratory compromise and death. Although the pathophysiology is not completely understood, it is linked to a mutation in the superoxide dismutase enzyme, which is an antioxidant that generally neutralizes superoxide, a toxic free radical. Other than symptom treatment, riluzole is the only treatment known to improve survival by preventing glutamate excitotoxicity indirectly. Spinal muscle atrophy, or SMA. This autosomal recessive disease is caused by a mutation in a gene coding a crucial protein, SMN, for motor neuron survival. As a result, anterior motor neuron death results, leading to diffuse whole body atrophy and lower motor neuron signs, such as fasciculations. SMA can manifest from infants to adults in varying forms of severity. In infants, it is most severe and called Werdnig-Hoffmann disease, or floppy baby syndrome, because of the abnormally low muscle tone observed. In addition to palliative care, no cure exists for SMA, but gene therapy, stem cell therapy, and SMN activation may eventually play a role in treatment. That's the end of this section. In the next one, we will pick up with movement disorders.